Hello and welcome everyone to this ENT session. And in the next 3 days, we shall be completing entire ENT. Usually, I start with ear, and then we talk about throat, and finally nose and sinuses. And I hope that you are well prepared to study for the next 3 days so that we can complete the ENT in the best possible manner. I promise you one thing, that I'll complete the entire ENT, every important points in the next 3 days, but you must be more receptive so that you make the best out of it. And 1 point or 2 points rather. Number 1, that if you have any query, anything to say, then please post this on the Telegram channel, not in the video that you're watching, not in the YouTube video, because I'm not watching YouTube video, so I'll not be able to see if you're saying something. So please post anything that you have to say or ask or any question on the Telegram channel, and so that I can see and I can answer your question. And don't wait for the end. Any question that you have while I'm teaching, please ask there and then, so that I can clear that doubt or question right away. Okay, so I'm told that the audio is not very clear. Okay, you can't open the So guys, I'm starting now. I'm hoping that everybody has got the access. I'm waiting for the audio to be fixed. They are fixing the audio. I think it is echoing too much. Hello. Hello, 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 hello. ठीक है. So I think guys the audio issue has been fixed. And we are ready to go. I hope I'm audible and I'm visible also. So like I was saying, we'll start with ear and we'll start with the anatomy of the ear. Now when I start drawing ear, I draw the pinna like this. Then I draw a canal, external canal. At the end of the canal there is a membrane. We all know it's called the tympanic membrane. Then there is a middle ear cavity, very small cavity. And in this small cavity, which is called the middle ear cavity, I draw 3 dots like this because there are 3 ossicles. And then inner ear I draw like a circle, although it's not a circle like this, but I prefer to do it. And there is a cochlea and the vestibule. From here, the 8th nerve carries a signal that goes via the brainstem into the auditory cortex. Now, this is what is called the auditory pathway, the pathway through which sound travel. It's called the auditory pathway, right? Now, a sound which comes from outside, let's say this is a sound, while I'm speaking, there is a sound. Now, this sound has to pass through this entire pathway to reach the cortex where it is perceived as sound, right? So, the question is, what happens to this sound as it is negotiating itself through this pathway? First of all, you have to know what kind of energy is a sound energy. Sound energy is nothing but a wave. It's a type of wave, and this wave has to negotiate through this pathway to enter the cortex where it is perceived as sound. So, when this sound passes through the external ear and it hits the membrane, what happens to the membrane? The tympanic membrane begins to vibrate. So, this is a change that has happened at the tympanic membrane. The wave has become vibration, but both wave and vibration are type of mechanical energy. So, that main type of energy has not changed, the subtype has changed, the wave has become vibration. Now, this vibration then is going to travel through the ossicles in the middle ear and enter the cochlea. What happens to this vibration in the cochlea? Another change happening here, and this is more profound change. What is the change? The vibration becomes action potential. Now, action potential is a different kind of energy. It's a electrical energy. It's not a mechanical energy, it's an electrical energy. So, basically the type of energy has changed now. The mechanical energy has become electrical energy. And when you change one type of energy into another type of energy, this is called what? This process is called transduction. So, in the inner ear, in the cochlea, what happens to the sound? There is transduction of sound. Now, this is your first important MCQ of the day. The function of the inner ear or function of the cochlea is called transduction. And then this electrical energy travels to the 8th nerve and the brainstem to enter the cortex where it is perceived as sound. So, in the entire auditory pathway, the most profound change that has happened in the cochlea, which is transduction. And without this change, you can't simply hear the sound. Now, if I tell you that transduction is the most important function of the auditory pathway, and therefore the most important function of auditory pathway happens in the inner ear, cochlea, isn't it? So, why do we have the middle ear at all? What is the purpose of the middle ear? If I don't have the middle ear, if I remove the tympanic membrane and the ossicle, the sound can still reach the cortex and transduction can still happen. So, why do we have the middle ear at all? What does middle ear do? Most people know the answer. What is the function of middle ear? Commonly we call it amplification of sound. It makes the sound louder, and loud sounds are heard better by everybody. But if you look into your question, if they ask you this question in the exam, which are the following is the function of the middle ear, if you are looking for the word amplification, you will never find that word there. There is another word with the same meaning, and that word is important. What is that word? It's called impedance matching. So, the function of the middle ear is impedance matching, and the function of inner ear is transduction. So, please guys remember these two very important things. Okay. So, a brief physiology. So, with this background, what I'll do, I'll start with the anatomy of the middle ear. So, I'll draw a similar diagram once again. Again, we have a pinna, a canal, a tympanic membrane, a middle ear with 3 ossicles, inner ear, cochlea and vestibule, 8th nerve, which carries the sound via the brainstem into the auditory cortex. Okay. Now pinna is more commonly called the auricle. Auricle is the right word for pinna. You can call it pinna, but auricle is the right word. Then this is external auditory canal. External auditory canal. Now this is the inlet of the canal. This that I am drawing with dotted line is the door of the canal, the inlet from where the sound starts entering the canal. This inlet is called external auditory meatus. So meatus is like a door to the canal. Now comes the important thing, this tympanic membrane, which I am shading with yellow. You know, tympanic membrane, which is called the eardrum commonly, is better remembered at, you know, what should you remember this as? Meringus. Remember, the tympanic membrane is also called meringus. Now why this name is important? Because they ask you the meaning of meringotomy or the meaning of meringoplasty. So when they ask you these terms, what is meringotomy or meringoplasty, you know that these are surgery of the meringus. Meringus is tympanic membrane, and that's why remember this. Whereas middle ear, which is also called tympanic cavity or tympanum. You can call it tympanic cavity. Tympanic cavity is fairly common name. Tympanum is the other name, and that's why the words like tympanoplasty and tympanotomy, they are referred to the surgeries of the middle ear. So if I ask you, what is the difference between meringotomy and tympanotomy? Otomy is making an opening. So in meringotomy, we make an opening on the tympanic membrane, whereas in tympanotomy, we make an opening in the middle ear. Or meringoplasty versus tympanoplasty. Plasty is repair, right? So meringoplasty is a repair of the tympanic membrane, whereas tympanoplasty is a repair of the middle ear. So that's why these terms are important, and you have to know these names. And inner ear, of course, is the labyrinth. Okay, so these are the terms or the names of various parts of the middle ear that you should be aware of. Why these names are important? Once again, I repeat the same thing, because they ask you the meaning of a meatoplasty versus canaloplasty versus meringoplasty versus tympanoplasty. So you can break these words if you know the names of these structures, if you know what these names stand for. And this ear is divided into three parts mainly. So this much of the ear is called the external ear. The small area is called the middle ear, and this is internal or inner ear. Everybody knows this. Every medical student will know this, right? Now, when we divide the ear into three parts, external, middle, inner ear, which is a very common thing to do, this part gets left out. The eighth nerve, the brainstem and the brain, and without this, your ear is useless. Finally, everything that happens in the ear must be transmitted to the inner ear, to the brain, to be able to perceive that as sound and balancing. So out of this part, the most important thing is the eighth nerve. Eighth nerve is very important for us, and this eighth nerve, which is after the cochlea, is also called the retrocochlear ear. This is another word that you must remember. You're going to come across this word many times as we proceed. Retrocochlear. Every time I use the word retrocochlear or you read the word retrocochlear, what should come to your mind? Eighth nerve should come to your mind every time you read the word retrocochlear. So for us, ear has four parts. What are the four parts? External ear, middle ear, inner ear, retrocochlear ear. Please keep that in mind. Okay. So with this background, we'll start with the anatomy of the ear. Now, if you ask me which part of the ear is most important for you from the exam point of view, it is the middle ear. It's the smallest part in terms of size and volume, but the most important part. Middle ear is not only important in terms of anatomy, it's important for physiology. Sometimes they ask an embryological question from here. Anatomy, of course, is very, very important. All the diseases of the middle ear are important. All the procedures that we do in the middle ear are important. All the investigations, surgeries, everything about middle ear is very, very important. That means indirectly what I am telling you, that when we discuss ear, we are going to focus more on middle ear. We are going to spend more time discussing middle ear. External ear and inner ear relatively are less important, and therefore we are going to devote less amount of time. Obviously, the time frame that we devote to each topic depends on the importance from the exam point of view, isn't it? So middle ear is going to be more important, but we'll start with the external ear. Tell me, what does external ear comprise of? See, external ear you can see comprised of the pinna, auricle, canal with meatus. And what about tympanic membrane, guys? Tympanic membrane you can see is at the border of the external ear and the middle ear. So who does it belong to? Border is always a problem. And the best solution of the border is either it belongs to nobody, no man's land, or it belongs to both partly. So in this case, we have decided that it belongs to both the parties. Tympanic membrane has two surfaces. There is the outer surface which faces the external ear, and there is the inner surface that faces the middle ear. So the outer surface of the tympanic membrane is a part of the external ear, and inner surface of the tympanic membrane is a part of the middle ear. So that's the solution. It belongs to both. So tympanic membrane also belongs to the middle ear along with the external ear, of course. That's what it means. Now, why is this important? I just told you a little while ago that the plasty of the meringus, tympanic membrane, is called meringoplasty, and plasty of the middle ear is called tympanoplasty. I just told you this, isn't it? And now I'm telling you that meringus is also part of the tympanum, which means every meringoplasty is a type of tympanoplasty also. So meringoplasty can be called a subtype of a tympanoplasty. So that keep this in mind. This is going to be useful towards the end of the day. Okay. So external ear comprises of pinna, auricle, canal with meatus, and the outer surface of tympanic membrane. So pinna is less important. The least important part as far as anatomy is concerned is the pinna. You only have to know two things about pinna. Number one, where does pinna develop from? But this is a very simple thing, but it's a very profound question. They ask many times, where does pinna develop from? Pinna develops from first and second branchial arch. Now we are not going to go into the details of all this. Just remember this very simple thing. If they ever ask you this question, this is the only thing you have to know about the development of the pinna. It develops from first and second branchial arch. And the second thing, what is it made up of? It's made up of elastic cartilage, which is also called yellow cartilage, except, now this is the question, which is the part of the pinna that does not have the cartilage? That's the question. Now there are two correct answers to this. There are two parts of the pinna which do not have cartilage. One is the lobule, and the second is the incisura terminalis. These are the two parts of the pinna we do not have the cartilage, lobule, and the incisura terminalis. Now whenever they ask this question, that which are the following part of the pinna does not have the cartilage, and they give you four choices, lobule is never given in the choices. They always ask you about incisura terminalis. Why? So this becomes MCQ. Incisura terminalis is a part of the pinna that does not have the cartilage, becomes an MCQ. But why this is so important and they never talk about lobule? I'll tell you that, but before that, let's go to this diagram that I've drawn. And where is the lobule? Lobule is this area, isn't it? This is the lobule. And if you have felt your lobule with your fingers, you know that lobule feels very soft compared to the rest of the pinna. And the reason behind that soft feel of the lobule is because lobule does not have the cartilage. And see, when I draw the diagram, I deliberately left a space here, a gap, because there is actually a gap there above the tragus because there is no cartilage, and this is called the incisura terminalis. Okay, this is the area. Easy to remember. You don't have to remember the diagram, the location. You have to remember the name. And I was asking you, why is incisura terminalis important? Because when we do surgery of the middle ear, incisura terminalis is one of the surgical approach to the middle ear. So they ask you a question on surgical approach to middle ear. That means when you do surgery of the middle ear, which is the route that you take or route that you take? In India, we pronounce it as route. In the Western country, they pronounce it route. We'll call it route. You are Indian, isn't it? So, which are the possible routes? कौन से रास्ते हैं मिडिल में एंटर करने के लिए? And there are three common routes for surgeries of the middle ear. One is called post oral route, as the name tells you, post oral is behind the auricle, pinna ke piche se. Then the second one is the transmeatal route. So this is through the external auditory meatus, and the third is the end oral route. These are the three common routes that we use for surgeries of the middle ear. Now each of the three routes has an incision, and the incision has a name. Now this is MCQ. The post oral incision is called Wild's incision. Please remember this name. The transmeatal incision is called the Rosen's incision, and the end oral incision is called Lempert's. It's actually called Lempert's 1 and Lempert's 2. So 3 routes to the middle ear surgery and 3 incisions. Remember these names, which incision in which route. They can ask you questions on this. Now one of the incision passes through the incisura terminalis. Can you guess which one? Or do you know which one? Anybody who wants to answer this question? Which of the 3 routes or routes incision passes through the incisura terminalis? And the answer is the last one. Lempert incision, Lempert's 2 actually, passes through the incisura terminalis. Remember this. Okay. But this is not a commonly used incision. Which is the most common incision is the first one. Post-oral or wild incision is the most commonly used incision during surgery of the middle ear. Second most commonly used is the Rosen's incision, and the least common of the 3 is the Lempert's incision. This is not important, but if you can remember, it could be helpful sometimes. Only this much about pinna, not too much, because we are saving our time for the middle ear. We need to spend time to the middle ear, as I told you in the beginning. Then we talk about the external auditory canal. Again, we are going to finish it off very fast because, like I said, we are saving time for the middle ear, right? So, in the canal, I will first tell you the regular points and then I'll tell you the more important point. Regular points like the length. The length of the canal is 24 millimeters. It is S-shaped. We all know we draw the canal like this, like a sleeping S. What is it made up of? Outer 1/3 is made up of cartilage and inner 2/3 is made up of bone. I'll come to this. Just remember, with the help of the diagram that I've drawn, I will try to explain this also. And then the lining of the canal. Everything in the body has to be a tissue lining. The lining is the skin around the pinna. The same skin goes inside the canal and lines the canal, which is keratinized squamous epithelium. So let's call it squamous epithelium. It's a keratinized squamous epithelium. Now these are the regular points about the canal that you have to know. And then you have to know the more special points, like there is something called foramen. They are called foramen of Santorini in the canal. There is a fossa called fossa of Haska in the canal. There are some hair cells and there are some glands. Okay. So these are the total number of names of the anatomical things in the canal that you have to know. The first 3 with the black that I have written are less important, like I said. The last 3 with the green that I have written are more important. Now, coming to this diagram, I told you that suppose I divide this is the canal from here till here, okay. If I draw a line here, let's say, and this line divides the canal into 2 parts, the outer smaller part, this part, and the inner 2/3, 1/3, 2/3, let's say it's here, okay. Now this outer 1/3, which is close to the pinna, is same tissue as pinna, which is cartilage, and the inner 2/3 is bony, okay. Actually, this entire inner part of the ear, this part that I'm shading now, is inside a bone. So this part of the external ear is also inside the bone, and therefore it's called the bony part of the ear. Now, which bone is this part of the ear in? Any idea? Which bone is this lying inside? It lies in the petrous part of the temporal bone. So it's petrous bone. petrous part of the temporal bone. Ear lies inside this petrous part of the temporal bone. Remember, that's one point. So that's why the canal in a tooth is called the bony ear. And at the junction of the bone and the cartilage, this is junction. At the junction of the bone and the cartilage, there are 2 or 3 microscopic openings like this on the anterior wall of the canal, and they are microscopic, mind you. You can't see them without a microscope. Tiny little openings, and these are called foramen of these are the foramen of Santorini. This name that I've written here, foramen of Santorini. Okay, some books call it fissure of Santorini. Hardly matters. But why is it important, this foramen or fissure? See, if there is an infection of the external ear, this external infection, what is external infection also called? External infection is also called otitis externa, and there is a pathogen in the external ear. So this is that dreaded pathogen. Okay, a bacteria, virus, whatever. This can easily come out of this canal because there is an opening in the canal or a foramen. It can come out of this foramen and infect the neighboring area. And they ask you questions based on this. What are the structures that can get infected in a patient of otitis externa through foramen of Santorini? It can infect the parotid gland and cause parotitis, or it can infect the skull base osteitis. So these are the 2 things that can happen in a patient of otitis externa. The question that was asked once, why is parotitis common in a patient of otitis externa? And the answer was due to foramen of Santorini. That's a simple thing. And foramen of fossa of Hurska, just remember that it's present only up to 5 years of age. At around 5 years of age, it disappears. So you and me, adults, we don't have this fossa of Hurska. These 2 are less important and they have no function otherwise. Now the next 2 are very, very important structure. You know why? Because they have a very important function of protection. They protect the canal from the pathogen that can enter from the canal. Canal is open, it is connected to the external environment, so the pathogen can easily enter through this canal and infect the skin of the canal. And that's why we need protection, the hair cells and the gland. And they ask you question from the gland. So what are the 3 questions or maybe 4 questions from the gland that are possible? Number 1, name how many types of glands and their name. And if there is a gland, it will have secretions. They ask you the name of the secretions of the gland. Then third thing, what is the property, any special property of these glands? And finally, can they create any pathology in the canal? So types, names, secretions, property, pathogen. These are the 4 or 5 things you have to know. So number 1, there are 2 types of glands in the canal. One is called the apocrine gland and sebaceous gland. Remember these very simple but very, very important points. Number 2, the secretions of the gland, the name of the secretion. Now sebaceous gland secretes sebum. Easy to remember, secretes sebaceous sebum, the name will match. Apocrine gland secretes cerumen. So which gland secretes cerumen, which gland secretes sebum is what they ask you. Any special property of these glands? They are antiseptic. So they can kill the pathogen and therefore this is how they protect you. Protection is the function. Plus also they are mainly fatty. They are made up of fat. The main content of most of the secretions in the body, on the skin actually, are fat. The sweat has a lot of fat, along with minerals. So these are the points that you have to know and they ask you questions on this. But now comes the more important part. See, these 2 secretions, that is sebum and cerumen, these 2 are always present in the canal, normally present in the canal. They are secretions. And that's why when you put your finger in the canal, it feels moist or wet because of the secretions. And they are not bad things. They are antiseptic. They are Dettol or Savlon you are carrying all the time in your body. But what is the lining of the canal? I told you the lining of the canal is skin, isn't it? Squamous epithelium. right? Rest of the body, canal also has skin. Now one thing about skin that we know, that skin constantly regenerates. Regeneration happens. The old skin dies, the new comes up. The same thing is happening in the canal also. So there's always some dead skin in the canal, and the dead skin in the canal can also be called keratin, because it's a keratinized skin, so it's keratin. So keratin, which is dead skin, is always there in the canal all the time. And there is one more thing which is present normally in the canal all the time: dust. Because canal is open, the dust keeps going in all the time. India में ज़्यादा होता है, India cities are more dusty, right? So point is that these four things are always present in the canal, but they are not supposed to accumulate in the canal. It's a cycle that's going on. They are being produced and they keep coming out. You know, this is a cycle. Sometimes they start to accumulate in the canal, and the accumulation is called the ear wax. Now comes 2 or 3 very important MCQ related to ear wax. A, the content of the ear wax. Simple but very important. Now you know the answer. Ear wax has 4 things: sebum, cerumen, dust and keratin. Or you can say ear wax mainly contains fat in it, isn't it? And when there is a ear wax, what do you do to remove the wax? How do you remove the ear wax? By syringing. We all know syringing is like flushing the canal. We take saline or water in a syringe and we flush the canal, irrigate the canal, and everything comes out. Okay, now syringing, there are 3 questions. Very important. Now this part is in external ear. Since we started the external ear anatomy, this is going to be your most important point from where questions are likely to be asked about syringing. Syringing is not anatomy, it's a procedure, but still we'll discuss the syringing. Now question number 1, what are the main indications for syringing? When do you need to syringe the canal? I just told you, for wax removal and also for foreign body removal. If a foreign body goes in the canal, we still do syringing to remove the foreign body. And I told you, what do we do in syringing? We take saline or water in a syringe and flush the canal. Now the important question they ask you is the temperature of the water of the canal, of the water or saline that you do for syringing. Now you cannot take a water from any bottle and start syringing. No, it's not allowed. That water must have a particular temperature, and that's the MCQ. What is the temperature? Same as body temperature, which is around 37 degree. So roughly body temperature 37 degree. Why is the question? If you take water which is, or saline which is warmer than this or colder than this, what will happen? So otherwise, that means if you are not careful about the temperature, it will stimulate something. What? It will stimulate lateral semicircular canal. LSCC is a short form of lateral semicircular canal. Now this is a very important anatomical structure in the ear. We'll discuss about this canal later on. Just remember that name if you don't know. And if you stimulate the lateral canal due to anything, what happens to the person? The person begins to have vertigo, the head starts spinning, and nystagmus. And vertigo can be serious. So see, a simple act of syringing can cause vertigo, which can be dangerous sometimes. And all you have to be careful about, if you want to avoid this vertigo during syringing, is ensure that the temperature is the right temperature. What is the right temperature? Same as body temperature, 37 degree. Okay. Now the second thing it can do syringing, see, canal has a lot of nerves. So obviously if I touch your body, depending on which part of the body I touch, that nerve will get stimulated. Canal also has nerves. So when you syringe, the syringe will touch the canal, the water will touch the canal, and the nerve gets stimulated. So it may stimulate, or you use the word irritate, Arnold's nerve. It's a very important nerve. Arnold's nerve is a branch of vagus 10th nerve that supplies the canal. Arnold's is a very popular nerve in the canal, and most medical students know this name. Now Arnold's nerve is a branch of vagus, and vagus is the 10th nerve. The longest cranial nerve in the human body is the vagus nerve. We all know it. Right from the brain, it goes right up to the GIT, isn't it? or the whole. It's a long nerve. Now vagus, besides many other things, also supplies larynx. The whole larynx is supplied by vagus. So when we talk about larynx tomorrow, we'll talk about vagus in a more details. Vagus pertaining to larynx only. And also the heart. Your heart is also supplied by vagus. So through the Arnolds during syringing, these two structures, the larynx and the heart, may get stimulated. When the larynx gets stimulated, patient begins to have coughing. And this was a question asked few years back, why the patient begins to cough when you syringe the canal? Because of the Arnolds or the vagus nerve. That's the answer. And it's very common in clinical practice. When you do anything in the canal, you see a lot of people, the patients, they start coughing, and you know the vagus is getting stimulated. And if the heart gets stimulated, it goes into bradycardia, drops, the heart rate drops. When the heart rate will drop, the blood supply will be compromised, especially to the brain. And when the blood supply in the brain is compromised, it can lead to syncope, blackouts. Syncope can happen, right? Which can be, cough is not dangerous, but syncope is dangerous. So see, a simple act of syringing can do three things. What are the three things it can do? It can cause syncope, it can cause coughing, and it can cause vertigo with nystagmus. So you have to know that vertigo, the cause, vertigo is due to the temperature difference. You are not careful about the temperature. And cough and syncope is because the stimulator of the Arnold's nerve. So they ask you, why does syncope happen? Why do vertigo happen during syringing? You have to know these points. Okay. So that's why syringing should not be taken lightly. It's not it's a simple procedure, but it can have consequences. And the last thing is, I told you the canal is S-shaped, isn't it? So during syringing, if you can make the canal straight, the S-shaped canal, if you can make it straight like this, then the wax will come out more easily. The foreign body will come out more easily. So how do you make the canal straight? Is by pulling the pinna. And the question is, you pull the pinna in which direction? Very, very important MCQ. It is pulled outwards, upwards, and backwards. Upwards, backwards, and upwards is the pull of the pinna, and this is another very important MCQ. So only this much about the canal anatomy, and in the bargain we have also talked about syringing, the basic points that you need to know. So we have done pinna, canal, and then it is time to show you the temporal bone. This is the temporal bone which has the ear inside it, and these are the views, the lateral view of the temporal bone and the inner view. I told you ear lies in the petrous part of the temporal bone. So can you identify the petrous bone? Now this is your triangular bone is the petrous. This is the petrous bone, and petrous bone is very important from the ENT point of view because ear lies inside this petrous part of the temporal bone. Okay. Now the last thing before I go to the tympanic membrane are the nerve supply. Nerve supply of the external ear. One nerve you know already, Arnold's nerve, but there are 4 more nerves. So total of 5 nerves. See, 5 names to remember, and remembering 5 names is never easy, isn't it? So we always devise tricks or how to remember. So one of the things you can remember that 3 out of 5 they are branches of cranial nerve. They are cranial nerve branches. These 2 are not branches of the cranial nerve. So guess where will they come from? If they are not from the cranial nerve, where will they come from to supply the canal? Any guesses? They are from the cervical plexus. So when you divide like this, it becomes easier to remember. Some from the cranial nerve, some from the cervical plexus, and all the 3 from the cranial nerve, the names start with the letter A. So we have 3 A's now, A, and the 2 from the cervical plexus, one of them is named as greater something, and the opposite is lesser something, greater and lesser. So the first A is Arnold's. We mentioned this, a branch of vagus, 10th nerve. The second A is auriculotemporal nerve. You know, auriculotemporal is a branch of third division of fifth nerve, V3 as we call it. V is 5, fifth nerve, third division mandibular nerve. So auriculotemporal is a branch of mandibular division of trigeminal, and the third A is auricular branch. It is more commonly called sensory branch of facial nerve, 7th nerve. So 10th, 5th and 7th, these are the three nerves that supplies the canal and the pinna and the outer surface of the tympanic membrane, and greater auricular and lesser occipital nerve. Right. So 5 nerves. So if I draw this pinna, canal and tympanic membrane, and I told you there are 5 nerves supplying the pinna, canal and the tympanic membrane. Do all these 5 nerves supply the pinna and all the 5 the canal and all the 5 the outer surface of the tympanic membrane? The answer is no. Now pinna has all the 5 nerves. So pinna has a rich nerve supply, all the 5 nerves. Canal has only first 3 out of 5. First 3 means the ones starting with AAA, cranial nerve. And the outer surface of the tympanic membrane is supplied by first 2 only, Arnold's and auriculotemporal nerve. So rest of the 3 nerves do not supply the outer surface of the tympanic membrane. Of course, inner surface of the tympanic membrane will be supplied by a nerve from the middle ear, because inner surface is a part of the middle ear. We will discuss this in a little while. Okay. So this will complete the nerves of the canal. So we have done the pinna, we have done the canal, and now it's time to talk about the tympanic membrane. Very important structure, tympanic membrane. This is how normal tympanic membrane looks like. Now in tympanic membrane, again first I'll tell you the regular points anatomy wise, which are not very important, and then I'll tell you the more important points. So regular points like the shape of the canal or tympanic membrane, the color of the tympanic membrane, thickness, area and landmarks. These are the regular points which every medical student should know, and then I'll tell you the more important points after I've done this one. So because this is less important for you, I'll quickly tell you the shape of the tympanic membrane is described as oval shape, and the color is called pearly white. Pearl is moti, isn't it? Pearly white. Some books use the word grayish white or gray. Now please remember, gray is the correct answer, but it is never the better answer. If you have to select between pearly white and grayish white, always go with pearly white, because I have seen MCQ book where they have selected grayish white over pearly white, which is not a correct answer. Thickness is a very thin structure, only 0.1 millimeter, which means that if you take 10 tympanic membranes and put them together, it only becomes 1 millimeter. See, each membrane is so thin, very thin and whitish in color. Because thin membranes can vibrate properly. We all know the tympanic membrane has to vibrate to produce hearing, and the thinner is the membrane and tighter it is, the better is the vibration. Now when we come to the area, you have to be careful about the language of the question, because there are 2 things they can ask you. They can ask you the total area of the tympanic membrane and effective area of the tympanic membrane. The total area is the entire membrane, which is 85 to 90 millimeters square. This is the total area. But this membrane is supposed to vibrate to create hearing. We know this, isn't it? The question is, does the entire membrane vibrate for hearing? The answer is no. The part that vibrates is called the effective area, and effective area is only 45 to 55 millimeters square. See, a large part of the tympanic membrane, nearly 40% of the membrane, or let's say 1/3, does not vibrate, only 2/3 of the membrane vibrates. So remember, that's why you have to be very careful what they are asking. Are they asking about the total area or the effective area? And then the landmarks. There are 4 landmarks. One is called handle of Malleus. Then there is lateral process. There is something called umbo, and there is cone of light. I'll show you all these names, but just remember as of now. So these are the regular points about the tympanic membrane, which are not very important, but if you can remember, it's going to serve you well. Before I go on to the main points, the more important points, let me help you identify some of the things on this image. So when you look at this image of the normal tympanic membrane, you can see the boundary of the tympanic membrane, this boundary. And boundary of the tympanic membrane has a name. Anybody knows the name of the boundary of the tympanic membrane? Anybody? It's called annulus. And then in the membrane, you can see a number of ossicles. Now this is the main thing you see. This is called the handle of Malleus. HOM stands for handle of Malleus, and handle of Malleus, mind you, is one of the landmarks. Now this, if this is your handle of Malleus, like this is the tip of the handle of Malleus. This is a tip point. The tip point is called the umbo. Then so umbo is a part of the handle of Malleus, and both are landmarks of the Malleus. And just above the handle of Malleus, there is another bone here, which is shown like this. This bone is the lateral process, which is also the landmark. And lateral process is also part of the Malleus. So the 3 structures that you can commonly see on a normal, this is a normal tympanic membrane. You should be able to see these 3 things, that is lateral process, handle of Malleus, and umbo. And incidentally, all the 3 are parts of the first ossicle, which is Malleus. And all the 3 are called landmarks of the tympanic membrane. Okay. Now when I draw the tympanic membrane, oval shape, I draw it like this. This is a tympanic membrane. We never draw the tympanic membrane straight over like this, slightly angled, and the handle of Malleus is drawn like this, and there is a lateral process which is like this, and this boundary is the annulus, as you can see. We know this. So this is how you usually draw the image of the tympanic membrane. Now if I divide this membrane into 2 parts at the level of the lateral process, so this is the lateral process, isn't it? So if I draw a line at the level of the lateral process like this, then the tympanic membrane gets divided into 2 parts, this upper smaller part and this lower larger part. And these parts have name. Upper smaller part is called pars flaccida, and the lower part is called pars tensa. Now the question is, if it is the same tympanic membrane, why does different part of the tympanic membrane have different names, pars flaccida, pars tensa? Because when you look at the tympanic membrane, or when you examine the tympanic membrane with the otoscope, they look different. Tensa means tight and flaccida means loose. So the lower bigger part looks very tightly held, so it's called tensa, and the upper smaller part looks very loose kind of a thing, so it's called flaccida. Okay. Now why they look different? Because the anatomy is different. Do you know how many layers tympanic membrane has? You will read your books, they will all say tympanic membrane has 3 layers, which is true. Tympanic membrane has 3 layers. But the 3 layers are present only in the pars tensa. Pars flaccida has only 2 layers, not 3. Okay. The middle layer is absent in the pars flaccida, and middle layer is a fibrous layer, or you can call it a muscular layer. So the tightness of the pars tensa comes from this middle layer, the fibrous tissue. which is absent in the pars flaccida, and therefore it is not tight, it is loose, and so the name is flaccida. Okay, so remember this, the anatomy is different, therefore they look different. The anatomy difference is the absence and the presence of the middle layer. And because of this different look, pars flaccida has one more name. The other name is Sharpnell's membrane. This is MCQ. Which of the following structure is called Sharpnell's membrane? This is how they ask a question. Which of the following is a Sharpnell's membrane? Pars flaccida is the Sharpnell's membrane. Remember that, very important. Now we have divided tympanic membrane into two parts, pars tensa and pars flaccida. Pars flaccida is further divided into four parts. How do I divide pars tensa into four parts? By drawing a cross with the center of the cross at the umbo. Meaning, if I draw a nearly vertical line passing through the umbo and a line almost right angle to this, see, this cross-like thing has divided the tympanic membrane into pars tensa into four parts. These four parts are called four quadrants. Quadrant comes from the word quarter. 1/4 is called quarter, and from there you get the word quadrant. Okay, so tympanic membrane pars tensa has four quadrants. Now assuming that this is the anterior end, this is the posterior part, the upper two are the superior part, below are the inferior part. So this quadrant is called antero-superior quadrant. Because out of the four, anatomically it is located anteriorly and superiorly. So this becomes posterior-superior quadrant, this becomes posterior-inferior quadrant, and this becomes antero-inferior quadrant. Four quadrants of the tympanic membrane. Okay. So these are the parts of the tympanic: pars tensa, pars flaccida. Flaccida has four quadrants, right? And this tympanic membrane is supposed to vibrate to produce hearing, isn't it? Now, does the entire membrane vibrate? The answer is no. The whole membrane cannot vibrate. Only the tensa vibrates. The flaccida does not vibrate. Second question, does the entire tensa vibrate? Can the entire tensa vibrate? The answer is no. The margin part, the annulus cannot vibrate because it is attached to the wall of the tympanic membrane. So this part near the margin area cannot vibrate. Can the center part vibrate properly? The answer again is no. The center part, which I have shaded with red, cannot vibrate because there is a handle of malleus, ossicle, bone. Bone are heavy structures. And if you place a heavy thing in the membrane, then that area cannot vibrate. So which is the part that mainly vibrates? The part that mainly vibrates is this part that I am shading now. So this is the part of the tympanic membrane that mainly vibrates properly and contributes to the hearing. This red marked area is the only part that vibrates. That's why this is the effective area. The whole thing is a total area, and this red marked area is the effective area. Okay, that's why the answers are different, total area versus effective area. But when I ask you this question, that which part of the tympanic membrane vibrates the maximum, how do you define this area? What do you call it? It is not pars flaccida, it is not marginal area, it is not central area. This area is called the peripheral part of the tympanic membrane. So keep this in mind, this is an MCQ. That which part of the tympanic membrane vibrates with the maximum amplitude? The answer is the peripheral part of the tympanic membrane vibrates the best with the maximum amplitude. That's an MCQ. And now we come to the most important thing related to the anatomy of the tympanic membrane that they ask in the exam. Now each of these four quadrants have some special features or points, and this is what they ask you. There are 7 or 8 special features about these different quadrants of the tympanic membrane. I'll tell you 4, maybe 5 that you have to know. And this is what you have to know in the anatomy of the tympanic membrane that they ask you. Anterior-inferior quadrant has 3 special features. Number 1 is the most common site of tympanic membrane perforation. So if there is a perforation of the tympanic membrane due to disease of the ear, then it most commonly happens in the anteroinferior quadrant. Second point, it's a preferred site of what? Preferred site of a surgery. Which surgery? Myringotomy with grommet insertion. So if you do this surgery called myringotomy and grommet, then it is preferred in the anteroinferior quadrant. Can you tell me for which disease this surgery is done? Anybody who knows the answer? Myringotomy with grommet insertion is done or preferred for which surgery, which disease? Please write in the comment if you know the answer, so that let's see. Myringotomy and grommet surgery is done for which disease? Anybody who knows? This is a very popular MCQ, that's why I'm asking you. So guys and girls, please write in the comment in the Telegram, myringotomy plus grommet is done for which disease? I'm waiting for your answers. Revati says ASUM. SK says AOM, acute otitis media. Anybody who wants to answer this question? Adnan says again otitis media, acute otitis media. Anybody else wants to answer this question? Lakshmi says AOM, R says AOM, Swati says AOM, Sneha says AOM, and AOM is a wrong answer. ASUM, AOM is a wrong answer, Malini. These are wrong answers. Okay, everybody has answered wrongly. Nobody has given me the correct answer. Garg, Dr. Garg, AOM, R says ASUM, Sankar says SUM. SUM is the correct answer. SOM is the correct answer. So Sankar has got it right, Sifa, Saji Khan has got it right, and Narendra has got it right so far. Yes, Anjir Nisar, SOM, Vishnuji Nair, OME is also same thing. OME is the other name for SOM. So that's the correct answer. Vishnu Nair. Okay. So serous otitis media or otitis media with the fusion is a correct answer, myringotomy with grommet. Okay. That's why I asked you, because see, so many of you got it wrong. Okay. Now posterior inferior quadrant is important again for a procedure. Posterior inferior quadrant is preferred in myringotomy. When you do myringotomy without grommet, then we do in the posterior inferior quadrant, and this one is done for ASUM, or you can call it AOM, acute otitis media. Okay. So see, these two surgeries, one is myringotomy with grommet, one is myringotomy without grommet. The indications are different and the sites are different, and that's why it becomes important for you from the exam point of view. And posterior superior quadrant, this quadrant is important because it's the most common site of traumatic perforation due to trauma. So see, otherwise perforation, as we have discussed, happens in the anteroinferior quadrant, but perforation due to trauma happens in the posterior superior quadrant, posterior part. But this is not important. What is more important is the treatment for traumatic perforation. Anybody who knows the treatment for traumatic perforation? When does traumatic perforation happen? Anybody who knows the answer? Traumatic perforation, treatment of traumatic perforation. Anybody who wants to write the answer to this question? How do you treat perforation of the tympanic membrane that is caused due to trauma? I thought most of you would know this very simple answer or question. Conservative management. And that's why it is important. You don't do anything to a traumatic perforation. Now this conservative management to traumatic perforation, we'll discuss the details of this a bit later. Okay, a bit later. And talking about the anteroinferior quadrant, I told you there are 3 points. One point is this one, second point is this one, and we have to talk of the third point. It has cone of light. So we all know cone of light is a landmark of the tympanic membrane, and it is present in the anterior-inferior quadrant of the tympanic membrane. What is a cone of light, by the way? It's nothing. It's simply a cone-shaped area like this, a triangular area, and this area is the brightest part of the tympanic membrane. It shines the most. Light is coming from this maximum. So it's called cone-shaped area with light in it, cone of light. That's how the name comes. And it is present in the anterior-inferior quadrant, and it's a landmark of tympanic membrane. Now, although these are the points about tympanic membrane that you have to know, all of them, but this part that you see here, now this part is very, very important. Maximum time when they ask you questions, it is from here. And you should also remember the image of a normal tympanic membrane, because as we proceed, I'll show you many other images of the tympanic membrane, and you should be able to differentiate a normal membrane from a diseased membrane. Okay, that's why this image should be etched in your memory forever. And let me show you how a traumatic perforation image looks like. Now this is how a traumatic perforation looks like. See, the location is in the posterior part of the tympanic membrane. So this is traumatic perforation. Okay, so this will complete the external ear, and now we come to our most important part, the middle ear. I've been telling you since we started that middle ear is very, very, very important. So we're starting with the most important part of the ear anatomy. If they ask you an anatomy question from the ear, 9 out of 10 times it is going to be the middle ear anatomy. And in the last 5 or 6 exams, they've asked anatomy question from the middle ear 3 times at least, maybe 4 times, So it's that important. It's very important. So please, guys and girls, please pay attention. For the next 2 hours, we're going to spend 2 hours anatomy talking about middle ear. Important. Okay. Now if I ask you, what is the shape of middle ear? Shape. Now shape of the middle ear depends on the view. Are you looking at the middle ear from the anterior view, AP view? If you cut the middle ear cornerly, then it becomes a AP view. Or are you looking at the middle ear from the side, sagittal view? In the AP view, middle ear is defined as biconcave. So if I draw it like this, the concavity on both the sides, so it's called biconcave middle ear. But if you look at the same ear from the side, sagittal view, it is more of ovoid or a cuboid, a shape of an egg, something like this, egg-shaped ovoid or cuboid. It means that if you take a middle ear and start rotating it, turning it, the shape will keep on changing. So there is no one shape of the middle ear, and it's very confusing. And so that we do away with this confusion, the middle ear is compared to a matchbox, box shaped cavity it's called, something like this. So when I draw the middle ear matchbox shape, I draw it like this. Why is middle ear called the match shaped box structure? Because middle ear has 6 boundaries, 6 walls. Any box, the room that you are sitting in has 6 walls. Middle ear also has 6 walls. There is a roof, there is a floor, there is an outer wall, there is an inner wall, there is an anterior wall, there is a posterior wall. So middle ear has 6 walls. And this ear is divided into 3 compartments. How do I divide the middle ear into 3 compartments? By drawing 2 lines. If I draw 2 lines like this, see, then I get upper 1/3, middle 1/3, and lower 1/3. Okay, so 6 walls, boundaries, 3 compartments. And what are the main contents? Besides many other things, the main contents are the 3 ossicles. We all know malleus, incus, stapes. There are few muscles and nerves also, but these are the malleus, incus, stapes. Ossicles are the main thing that they talk about. Okay. Now, what are these compartments called? 3 compartments. The upper compartment is called epitympanum. Epitympanum has one more name. It's also called attic. Middle 1/3 is called mesotympanum. Lower 1/3 is called hypotympanum. So epitympanum, attic, mesotympanum, hypotympanum. So we know the names of the 3 compartments. Now 6 boundaries. For showing you 6 boundaries, I will draw another diagram. I'll use another diagram, and to this diagram I shall add the external ear and the inner ear. So if I add the external ear, let's say the canal comes about like this, the pinna can be drawn like this, and a simplified inner ear image can be drawn like this. See, this is like the first diagram that I had drawn. The only difference this time is that the middle ear looks like a box, otherwise very similar thing, isn't it? So when I draw it like this, it becomes easier to name the walls, because now I have to call this wall the outer wall or the lateral wall, because it is facing outwards. And so the opposite wall, this wall becomes the inner wall or the medial wall. This has to be the roof, and this has to be the floor. The one in the front, this one is the anterior wall, and the one behind this is the posterior wall. Easy? Now out of the 6 boundaries, you know one. Which boundary do you know? Make a guess. You know one boundary of the middle ear already. You know the outer boundary. The outer boundary is tympanic membrane, isn't it? So everything tympanic membrane can be drawn like this. And so everything that we discussed about tympanic membrane is applicable to the outer wall. We just discussed tympanic membrane. So everything that we discussed is applicable to the outer wall. So there is a handle of malleus, there is a lateral process, there is umbo, and there is a cone of light. Cone of light. So all this is applicable to the outer wall of tympanic membrane. What about inner wall? Inner wall is not straight the way it is shown like this. It's not straight like this. Inner wall has a bulge in the center. So inner wall should be drawn like this. There is a bulge in the center of the inner wall, and this bulge also has a name. What is the name of this bulge? It's called promontory. So it's a very popular name. I'm sure most people know this name. Promontory is the inner bulge on the inner wall of the middle ear. Then roof is called tegmen tympani. They've asked this name in the exam in the past, so it makes sense that you remember this name. Tegmen tympani is the roof of the middle ear, MCQ. And then floor. Floor does not have a name, but floor has 2 important things. Or below the floor, there are 2 important things. One is ninth nerve, and the other is jugular vein. These 2 structures, they lie just below the floor of the ear. So see, you already know about 4 out of 6 boundaries. You know the roof is called tegmen tympani. Below the floor there is ninth nerve and jugular vein. Outer boundary is tympanic membrane. Everything that we discover about tympanic membrane is applicable to the outer boundary. And inner boundary has a bulge called promontory. So the only walls that are left to decide or describe or teach are the anterior and the posterior walls. Anterior wall and the posterior wall, which are the main walls actually from the exam point of view. So before we come to these 2 very important walls, I'll talk about a couple of things. See, ninth nerve, which is below the floor of the ear, is important. You know why? Because it sends a branch that enters to the floor to supply the entire middle ear. So your entire middle ear is mainly supplied by a branch of the ninth nerve. Do you know the name of the ninth nerve branch that is going to enter the middle ear? It's called Jacobson's nerve. So where does the Jacobson's nerve enter? The Jacobson's enters the middle ear. If you remember, the middle ear is called tympanum. So it enters the tympanum to form a plexus in the tympanum. What is that plexus called? Tympanic plexus. Obviously the plexus in the tympanum is called tympanic plexus. It is formed by a branch of the ninth nerve called Jacobson's, and it enters the middle ear through the floor. So both are J. Jacobson's nerve is J and jugular vein is J. Both J are below the jokers are below the floor. Jokers नीचे ही होते हैं. Jokers cannot rise. Jokers will always remain below the floor. The only joker which I know who has risen is the president of Ukraine. He was a comedian, I am told. Now he is the president of a country which is in a war. Otherwise, jokers नीचे ही रहते. So joker, that's how you remember. Jokers are below. JJ, Jacobson's jugular vein. Okay. And then I'll talk about the tympanic membrane a little bit more. And with that, I'm going to draw a very, very important diagram. This next diagram is going to be very important for you. After we have done that one, then we'll go and discuss the anterior and the posterior wall, which are very important walls. Okay. So, tympanic membrane, I told you, has 3 layers in the pars tensa and 2 layers in the pars flaccida. So, if I cut the tympanic membrane and look at the membrane from the side, I should draw 3 layers on the tympanic membrane like this. Let's say these are the 3 layers of the tympanic membrane, and the total thickness is 0.1 millimeter. Obviously, there is no gap in the tympanic membrane layers, they are all touching each other, but this is how we show the tympanic membrane. Is the audio better now? Okay. So let me contact the team, the technical team. फिर से बोलो.
आपका माइक का जो वो है ना यूएसबी कुछ भी है वो हिलता है उसकी वजह से आवाज आ रहा है.
अच्छा.
माइक चेंज करना पड़ेगा.
अभी तो चेंज नहीं हो सकता आज. तो अभी इसको करो, कैसे करोगे?
हाँ, एक मिनट सर, एक मिनट निकाल के दोबारा लगाइए एक बार.
लगा दिया मैंने, किया है.
हाँ ठीक है सर.
ठीक है.
Okay, then continue.
So guys, I hope the audio is okay now. So if the audio is okay, I'll go ahead, I'll start again. So hello, is it okay? Is it okay? So yes, it's better now. So I was talking about the tympanic membrane. Okay. So I told you that before I talk about the anterior and the posterior wall, I will talk about the membrane a little bit more. Now what I've done here, I've drawn the three layers of tympanic membrane. So obviously this part is the pars tensa because there are three layers, and the upper part is the pars flaccida with two layers, and the total thickness is 0.1 and there is no gap between the layers. So I can draw the external ear like this. This is a middle ear, pinna, there is a middle ear, and there is the inner ear with cochlea and the vestibule. So this is your promontory. Now if I draw the three ossicles, malleus, incus, stapes, the malleus, there is a handle of malleus here. This is the handle of malleus. The tip is the umbo. There is a lateral process. There is a neck of the malleus, and there is a head of malleus. Now this is how we draw the malleus. So this becomes the handle of malleus. This becomes the umbo. This is the lateral process. All these three are landmarks of tympanic membrane. We know this already. Look at the lateral process. It is facing outward laterally. That's why it's called the lateral process. This becomes the neck of malleus, and this is the head of malleus. So out of many parts, these are the five important parts of the malleus that you should be aware of: head, neck, lateral process, handle, and umbo. Now the next ossicle is incus, and incus forms the joint with the head of malleus. So incus you can draw like this. So this is your body of incus. Then this is your long process of the incus. So when you have a long process of incus, there has to be a short process also. Short process of incus I will mention a little while later, because short process is on the back side of the body and it goes on the posterior wall of the middle ear. So when I talk about the posterior wall of the middle ear, I will mention the short process of the incus also. So keep in mind that name. But there is one more process. Besides body, long process, short process, there is a small process which I can draw like this. Can you tell me what is this process called? This process is the lenticular process. So incus has the body which forms the joint. There is a short process which is not shown in this diagram. It is on the back side. There is a long process. At the end of the long process is the lenticular process. Now why is lenticular process important? Because it is the lenticular process that forms the joint with the third ossicle, which is stapes. So lenticular process of the incus is going to form the joint with the third ossicle, which is stapes. Which part of the stapes? The head of the stapes. So there is a head of the stapes like this. Then there is a neck of the stapes. There is head, which is forming the joint. There is a neck, and then there is a crura. Crura means curved bone, a bone which is curved like this. So we draw the crura like this. This is your crura. Okay. So what you can see now in the stapes is the head of the stapes, the neck of the stapes, and the crura of the stapes. So this much of the stapes is called the suprastructure of stapes. Suprastructure of stapes. What is missing in the stapes? The foot plate. So stapes without foot plate is the suprastructure of the stapes. And if you add a foot plate of the stapes here, then it becomes the complete stapes. Okay, so this is your foot plate of the stapes. Foot plate of the stapes. So stapes minus foot plate is the suprastructure. And why is this important? Because the first two ossicles, they develop from the first branchial arch. The suprastructure of the stapes develop from the second branchial arch, but the foot plate does not develop from the branchial arch. And that's why this becomes a very important MCQ, that where does the foot plate of the stapes develop from? And the foot plate develops from the OT capsule. It's a very popular MCQ, very commonly asked, because the development of the foot plate is different from the rest of the stapes. So we have called it a different category. That's why foot plate is not a part of the suprastructure of the stapes. Okay. Now, why have I drawn? No, otic vesicle, Dr. Safna, gives rise to inner ear. Okay, we'll talk about that later on. Otic vesicle is not foot plate. Otic vesicle is different thing. Otic capsule is different. Otic vesicle is different. Safna, please be aware of that. Please be mindful of that. But why have I drawn this diagram? For two reasons. I'll come to that. But before that, let me show you the ossicles. Obviously the malleus, incus and the stapes, and this is your foot plate. Okay. The first two ossicles are from the first branchial arch, the suprastructure is from the second branchial arch, the foot plate is from the otic capsule. And there are two joints. Which are the two joints? This is one joint between malleus and incus, incudo-malleolar joint, and the second joint is this one between incus and the stapes, incudo-stapetal joint. Incudo-malleolar joint is a type of saddle joint. And incudo-stapetal joint is a type of ball and socket joint. And both these types, that is saddle joint and incudo-stapetal joint, they both belong to a type called synovial joints, synovial joints. They're both synovial joints. Okay. But actually the ossicles are very, very small. If you take a CT scan of the temporal bone, I had shown you the temporal bone. This is a CT scan of the temporal bone. And middle ear, look at this, middle ear is only this much. This cavity that you see is the middle ear. So middle ear is actually a very, very small cavity. Look at the mastoid. This is the mastoid, such a big area compared to the middle ear. Look at the inner ear. This whole thing is inner ear, such a big area. But middle ear is very, very tiny. Okay. Now can you see inside the middle ear this white thing? This white thing, this one and this one, they are the ossicles. These are how the normal ossicle in the middle ear look like. And this look of the normal ossicle on the CT scan is described as ice cream cone appearance. This look of the normal ossicle is described as ice cream cone appearance. So if you can see an ice cream cone appearance of the ossicle in the middle ear, it's a normal ossicle. If you cannot see the ice cream cone appearance of the ossicles in the middle ear CT scan, then there is some disease or damaged ossicle. That's how you can realize the ossicles are normal or they are damaged, because of this look ice cream cone. You don't have to identify the image, you have to remember that name ice cream cone appearance. So this image is not that important. But now I come to this one. Why did I draw this diagram? Now comes a very, very important two things. Tympanic membrane looks like a single layer. It is three layered, but Actually, if you look at the tympanic membrane, they don't look like separate layers. I told you already that the whole membrane can look like this. This is your tympanic membrane. This is the middle wall of the middle ear, and this is the floor. Now, if you look at the middle ear, why it's called biconcave cavity? This is your promontory. This bulge is the promontory. Now, please note that normally our middle ear is in contact only with the first ossicle malleus. It is not in contact with the incus or the stapes or the promontory. This is a normal tympanic membrane, and there is a station tube that maintains the pressure of the middle ear. We all know. If the station tube gets blocked, we'll discuss station tube in a little while from now. But if the station tube gets blocked, the middle ear cannot function normally, and it becomes negative pressure in the middle ear. Now, is negative pressure in the middle ear a common occurrence? The answer is yes. Negative pressure in the middle ear is a very, very common occurrence. Your station tube gets blocked very commonly. Every time you have cold, rhinitis, sinusitis, change of weather, when you are in a flight and all, your station tube gets blocked very easily, and the pressure of the middle ear becomes negative very, very commonly. And what does negative pressure do? The negative pressure in the middle ear pulls the membrane. The membrane gets pulled inward, and a membrane comes here like this. Here. And when the membrane gets pulled inward like this is called retracted tympanic membrane. So, retraction of the tympanic membrane, which is called retracted tympanic membrane, is a very, very common occurrence on the tympanic membrane in the middle ear actually. So, all this is very common. The blockage of the station tube resulting in negative pressure in the middle ear and retraction of the tympanic membrane is very, very common. Now, look at the way I have drawn the retracted tympanic membrane. Although this membrane is retracted, it is still not touching the incus or the stapes or the promontory. Now, this is called grade 1 retraction of the tympanic membrane. When it is retracted, but it is still not touching the incus or the stapes or the promontory. Sometimes it is more retraction, more severe problem. So, the membrane comes like this. Look at this membrane, it is not touching the incus and the stapes also, but not the promontory yet. This is called the grade 2 retraction. So, in grade 2 retraction of the tympanic membrane, it will come in contact with its stapes and the incus, but not the promontory. And when it comes in contact with the promontory like this, then it's called grade 3 retraction, So, retraction of the tympanic membrane has gradings. Grade 1, grade 2, grade 3, grade 4. And what is grade 1, what is grade 2, what is grade 3? I have just explained to you. It's very easy to remember. But please remember because they ask you questions. Now, let me give you the details of these gradings. Grade 5 is not there. So, these are the 4 grades of tympanic membrane retractions. And the grading was done by a gentleman called Said. They've already asked this name in your exam. Who graded the tympanic membrane into 4 grades? Said is the correct answer. Please remember that name. So, what is grade 1? It is slight retraction, not up to incus. Grade 2, tympanic membrane onto incus or incudostapedial joint, but not promontory. Now, this word is very important, but not promontory. Because if it is onto promontory, then it becomes grade 3. And in grade 4, it is adherent onto the promontory. It is fixated onto the promontory. It is plastered onto the promontory permanently. Okay. So, it's very, very easy to remember. In grade 3, it is just touching the promontory. Only touching. In grade 4, it is adherent onto the promontory. Chipak jana is grade 4. Now, I know of MCQ books, they claim that there was a question based on the image of the grading, and they asked you, like they had shown one of these images of the tympanic membrane, and they had asked what grade of retraction this is. My dear friends, this question was never asked in no exam. I can give you with all confidence. This question was never asked in any exam, and I can bet one more thing, they will never ask you this question in future as well. They will ask you this thing. This has been asked 3 times. Once they ask the name of the person, and 2 times they ask what is grade 2 retraction. Twice they have asked grade 2 retraction. Okay, theory they will ask you, image they will never ask you. Why? Because even a seasoned ENT specialist cannot identify sometimes the grading. It's not easy, it's a very, very difficult thing to know the grade. You know it is grading, it is retraction. What grade? If you suppose there is grade 2 retraction, and if you ask 2 different ENT specialists, senior specialists, good specialists, they may give you a different answer. One may say it is grade 2, one may say grade 3. It's so difficult. That's why to ask such thing to MBBS guy is like a crime, for, in my opinion. They will never ask you, they will never ask. It is given in MCQ books, that's another point. But I'll give you a hint that what should you look for, what should you look for to be able to grade based on the image. Like I said, it's not easy, it's not going to be easy for you. Now look at this tympanic membrane, the first one. You can see this is the annulus, and the only ossicle that you can see is this one. Okay, so when you can only see one ossicle, handle of malleus only with the lateral process, this is the lateral process, and if it is graded retraction, this is grade 1 retraction. You can't see the incus and the stapes and the promontory. Now look at this one, the next image. This is your handle of malleus. Now this one is the handle of malleus, but what is this one? This is your incus, long process of incus. When you can see the incus also along with malleus, it has to be grade 2. You can't see the promontory properly in this area. So this is grade 2 retraction, where you can see the handle of malleus and the incus. And look at this image now. This is your handle of malleus, this is your incus, and you can see a small part of the promontory here. If you can see a small promontory along with the incus and the malleus, then that means it is touching the promontory, so it is grade 3 retraction. And look at this one, you can see the entire promontory along with the handle of malleus and this incus. A big part of the promontory is grade 4 retraction. So now if you compare these 4 images, it might become a little easy for you, but I will suggest that don't spend or waste your time trying to look at the images to identify the grading. It's not easy and it will never be asked, in my opinion. And even if they ask you, most people will make a mistake. When in your exam, if everybody makes a mistake, most people, then it doesn't matter. It neutrals, evens out. But this one is important. This thing is very, very important. Okay. Now coming back to this image, I told you this image I had drawn for 2 reasons. One, to explain you the grading, 4 grades. The second very important thing. See, if I ask you to identify, you know that this is your tympanic membrane, pars tensa, and this is pars flaccida of the tympanic membrane, obviously. Upper part is pars flaccida, and this you know is the neck of malleus. You know this, right? Now from the neck of the malleus to the pars flaccida of the tympanic membrane, there is a membrane running. A membrane, a ligament which goes like this, in this direction. And because this membrane is from the malleus and is going laterally toward the tympanic membrane, it's called lateral because the direction is lateral. Because it comes from the malleus, it is malleolar fold. Okay. So in this image, you can see 3 names. You can see the lateral malleolar fold 1 name. You can see the neck of malleus 2nd name. You can see pars flaccida the 3rd name. Now between these 3 names, you can see there is a tiny little space. This space which I am shading with yellow. This space has a name. What is the name of this space between the lateral process of malleus, lateral malleolar fold, neck of malleus and the pars flaccida? This space is called the Prusac space. So this area is the Prusac space area. I will show you a better image also of Prusac space later on. This is just to explain to you. Okay, Prusac space. So Prusac space, two things. One, the three boundaries of Prusac space: the superior boundary, the inner boundary, and the outer boundary. The superior boundary is lateral malleolar fold. The inner boundary is the neck of malleus, and the outer boundary is two things. One is pars flaccida, Sharpnell's membrane, and there is something called scutum. Just remember this name. I told you when I show you the image, I will show you what the scutum looks like. It's a small bone called scutum. So these are the three boundaries of the Prusac space. And what is the importance of Prusac space? Why it is important? Because Prusac space is the most common site of colostoma formation. And this is the importance of Prusac space. It is the most common site of colostoma formation. So retraction and Prusac space are the two things that I wanted to explain with this help of this diagram. Okay. And now we come to those two boundaries that we are left with. Which are the two boundaries we are left with? The anterior wall and the posterior wall. So let's talk about these two boundaries. But before I talk about these boundaries, tell me something. When I do otoscopic examination and when I look at the tympanic middle ear, when I look at the middle ear, which is the only wall that I can see from outside? The only wall that I can see from outside is the tympanic membrane. I cannot see rest of the walls, they are inside, isn't it? Now imagine something else, that out of the 6 boundaries, I have removed the tympanic membrane. One boundary has been removed. And now if I examine from outside, which wall of the middle ear do I see? I will be able to see the inner wall with promontory. Above this there is a floor, roof. Below this there is a floor. On one side there is anterior wall, one side there is a posterior wall. So there is a box, a room in which one wall has been removed. So there are 5 walls now. If you open that box, how does the open box look like? If you take a box, any dabba, and if you remove one boundary, tympanic membrane, and rest of the 5 boundaries, if you open the box, how will the open box look like? Can I draw it like this? The open box. This becomes the roof, this becomes the floor, and this is the inner wall. On one side has to be anterior wall, one side has to be the posterior wall, and the outer wall has been removed. Inner wall also has a bulge called promontory. So I draw the promontory in this diagram like this. So this is your promontory, the bulge on the inner wall of the middle ear. So we are going to use this diagram to talk about the anterior and the posterior wall of the middle ear. Okay. So Dr. Safna is asking, is the retraction pocket and the Prusac space same? The answer is no. Retraction pocket is a pathology, a deviation from normal, where the tympanic membrane gets pulled in from its normal place. It shifts when the tympanic membrane shifts from the normal place inwards. That is called retraction, and it is gradings. So it's a pathology, it's a disease. Whereas Prusac space is an anatomical space, which is a normal space in the middle ear, but that space is important because it leads to a formation of colostoma most commonly. If there is a colostoma, which is another disease, it happens in the Prusac space. So that makes this anatomical structure important, but they are two different things. Retraction is when the tympanic membrane is pulled in, and Prusac space is a space in one part of the middle ear, small space, which has boundaries which I have discussed. Okay. So if there is any confusion, what I will do is, after we have done all the 3 days, at the end of our ENT session, I will make a PDF file of this whole thing that I am writing. You are making a notes, I am also making notes for you, and when I am done, I will make a PDF file and share in this Telegram group for you to check if you have missed anything okay, or if you have not understood anything. So with that brief detour, we are now going to talk about boundaries. We are continuing with the boundaries. Let us start with the anterior wall of the middle ear. This anterior wall. Do you remember I told you that below the floor there are two things. There is a ninth nerve and there is a vein like this. What vein is this? Through which the blood is flowing. This is a jugular vein, internal jugular vein, internal jugular vein. So below the floor is an internal jugular vein, and anterior to the anterior wall there is an artery running like this. Do you know which artery is this? This is internal carotid artery. So two big vessels, jugular vein and internal carotid artery, the blood is running in this direction, are just outside the middle ear but very close to the boundaries. But these are outside the boundary. We are talking about structures on the boundary. On the anterior boundary, there are two openings. There is a small opening like this and there is a larger opening like this on the anterior wall of the middle ear. Okay. This smaller boundary, this one, is called canal for tensor tympani muscle. Only the name is important, nothing else. Canal for tensor tympani. So from the name I understand, a muscle comes out of this canal into the middle ear, and the name of the muscle is tensor tympani muscle. If there is anything else important about this canal, that will be discussed in anatomy. From the ENT point of view, it is not important. But the bigger opening is a more important. This is important from the ENT point of view. This is a eustachian tube opening. Very, very important tube, the eustachian tube, and they ask you 3 or 4 very important MCQs from the eustachian tube. But from the name I understand, it's a tube like this. A tube with 2 ends or 2 openings. This end of the tube opens in the anterior wall of the middle ear. Do you know where this end opens? The other end of the eustachian tube opens where? Anybody? This end opens in the lateral wall of nasopharynx. It opens in the lateral wall of the nasopharynx. So eustachian tube runs from the anterior wall of the middle ear to the lateral wall of the nasopharynx. Now where is nasopharynx? It's a part of the pharynx that lies behind the nose. Nasopharynx, pharynx behind the nose. You know, tomorrow we'll discuss pharynx, throat. But when I draw pharynx, I draw it like this. I draw the pharynx like this. And this pharynx is divided into 3 parts like this, and this part of the pharynx is called the nasopharynx. And in this nasopharynx, which is behind the nose, you should be able to see the opening of the eustachian tube, which in the nasopharynx looks like this. Something like this. Now, all this is important from the anatomical point of view, but this is more important when we discuss pharynx. So, tomorrow, once again I am telling you, when we discuss nasopharynx or pharynx, I will draw this similar diagram again. I will also show you the image, the actual image of the nasopharynx, how it looks like. Right now, just related to the eustachian tube. Okay, this is how the eustachian tube opening looks like. And there is a bulge around the tube like this. You can also see a bulge like this. In the nasopharynx, I am drawing here the bulge something like this. Okay, and this bulge in the nasopharynx end formed around the eustachian tube has a name. This bulge is called torus tubaris. Torus is anything which is bulging, and tubaris is from the tube you get. So this bulge is the torus tubaris. You can see this in the nasopharynx when you do nasopharyngoscopy. We'll discuss this tomorrow again. I'll show you the image also. So with this background, let me talk about the other MCQs from the station tube. They ask you the length of the station tube. Station tube is 36 millimeters long. And what is it made up of? Remember canal, what is canal made up of? External aortic canal. I told you canal outer 1/3 is made up of cartilage, inner 2/3 is made up of bones. In the station tube, the reverse is true. In the station tube, outer 1/3 is bony and inner 2/3 is cartilage. It is opposite of canal. So that's how you remember. Third point, how is a child's tube different from adult? The station tube of a child is different from the station tube of the adult because the station tube of a child is shorter, it is wider, and it is straighter. That means it is more horizontal as compared to adult. So the station tube of a child compared to adult is shorter, wider, and straighter. And now comes a very, very important point. I talked about torus tubaris, this one. Torus tubaris. Now, what is the cause of this bulge formation? Or how is torus tubaris formed? Torus tubaris is formed because of three muscles which are attached here. Three muscles. Which are the three muscles? And these names are important. Tensor veli platani, levator palati. These two are both muscles of the palate. The two main muscles of the palate are these two muscles. So this palatal muscle also attached to the station tube, and they result in the formation of this bulge called torus tubaris. But there is one more muscle contributing to the torus tubaris, and that muscle is a pharyngeal muscle called salpingopharyngeus muscle. So these three things, they result in the formation of torus tubaris. Now comes the most important question related to the station tube. The function of the tube. So who will tell me the function of the station tube? I am sure most of you know that station tube has two functions. One I mentioned briefly, it balances the pressure of middle ear. So middle ear pressure, the air pressure of the middle ear is balanced because of the station tube. And what is the second function? Drainage. Whatever secretion is produced in the middle ear, it comes out of the station tube. So it's a drainage function. And both are very important functions of the station tube. Without these two functions, your middle ear is nearly useless. And I told you, if you remember, it is very common for the station tube to get blocked. And if the station tube gets blocked, both these functions get disturbed. So what will happen when the station tube gets blocked and it cannot function properly? When the balancing of the pressure is disturbed, this causes negative pressure in the middle ear. And negative pressure can lead to two things. One we discussed. It can cause retraction of the tympanic membrane, remember? And I also told you about the retraction grading, 4 grades. I also gave you the name of the person who did this grading, SAD, SAID, all that you know already. But this can also lead to another thing called barotrauma. Trauma due to sudden change of middle ear, pressure in the middle ear is called baro, is sudden change of pressure, trauma. Okay. So these are the two things that can happen if somebody's station tube gets blocked. And if the drainage also gets disturbed, there is going to be a collection of fluid in the middle ear. Obviously, if a drain of the bathroom or the sink is blocked, the water starts accumulating, collection, and this water will get infected, and now there is an infection of the middle ear. What is infection of the middle ear also called? Infection of the middle ear is also called otitis media. otitis media. See, the point is, if a station tube gets blocked, it can lead to three problems. It can lead to retraction, it can lead to barotrauma, it can lead to otitis media. Three problems. Okay. Retraction we have discussed already. Barotrauma, you just don't know the meaning of this. But otitis media is a very important ear topic. Do you know? In otitis media, they ask you a lot of MCQs. And to discuss the entire topic otitis media, it takes more than 2 hours. It's a long topic. So I will do otitis media properly after we have done the anatomy and the investigations. Properly we'll discuss because it takes a long time. But keep one point in mind, that the heart of the otitis media is the station tube block. If there is otitis media, one thing is sure, the station tube is damaged, blocked, and that is why there is otitis media. Okay? And because the station tube can lead to so many problems, you may have to investigate the station tube. So which is the best investigation for station tube? There are number of investigations. The best is tympanometry. See, I am not telling you this is the only investigation. I told you there are 5 or 6 options you have, but this is the best of the lot. And this will complete all the important points that you have to know about your station tube. A very, very important tube, lot of points here. Please remember each of them because every single line is a potential MCQ for you. Okay, this also completes the anterior wall. Which wall is left now? I'm sure you are talking about posterior wall, isn't it? Yes, but before posterior wall, I want to complete the inner wall. Inner wall, few points I still need to be told. So first I will talk about inner wall, which is medial wall, and then we'll talk about the posterior wall. In the inner wall of the middle ear, you know one thing already. You know about a bulge called called the promontory. But actually, in the inner wall, there are 2 bulges. There is one more bulge. There are 2 windows also. And there are 2 more things. So this is how I suggest that you remember the inner wall. 2 to 2, the rule of 2 applies here. 2 bulges, 2 windows, 2 more things. 2 bulges you know already. One is promontory, which I have drawn also, I have shown before. The second is bulge of LSCC. Do you remember LSCC? Lateral semicircular canal, which we discussed during syringing mentioned. So that bulge of the lateral canal lies on the inner wall of the inner ear, middle ear. So in this diagram, where should I draw the bulge of the lateral canal? Promontory I have drawn already. Bulge of the lateral canal where? In the top corner. Here there is a bulge of the lateral canal. And never disturb this lateral canal, because this canal is disturbed, what happens? Vertigo and nausea. Remember, if you disturb the lateral canal, there is going to be vertigo and nausea. Then there are 2 windows. Everybody knows there is an oval window and there is a round window. And the name of the window comes because of the shape of the window. One is oval shape, one is round shape, oval window, round window, obviously. But where should I draw these windows? See, oval window is here. So this is how I draw the oval shaped window. Please note, this window lies on the upper part of the promontory, very close to the posterior wall, isn't it? And round window should be drawn here. Round shaped window, round window. And this is on the lower end of the promontory, again very close to the posterior wall. So both these windows are very close to the posterior wall, but one lies on the upper part of the promontory, one lies towards the lower part of the promontory. And there are 2 more things. Which are these 2 more things? there is a facial nerve. Seventh cranial nerve is a very important nerve from the ENT point of view, and there is something called fistula antefenestrum. So these are the two of the posterior wall, two bulbs, two windows, two more things. Now facial nerve, if I have to draw the facial nerve on the inner wall, it runs above the oval window like this. This is how we draw the facial nerve. So this facial nerve, which is here running in the horizontal direction, this part is called the horizontal part of the facial nerve. Horizontal part. And see, it travels and comes onto the posterior wall. On coming to the posterior wall, what happens to this nerve? This nerve turns and runs downwards and out of the ear like this. So this part of the facial nerve on the posterior wall, because going downwards, is called the vertical part of the facial nerve. That means facial nerve on the middle ear has two parts: the horizontal part, which is mainly on the inner wall. It also has the vertical part, which is mainly on the posterior wall. And then there is a fistula antefenestrum. What does the word fistula mean? Fistula stands for fistula. So there is a fistula, a very tiny microscopic fistula in front of the oval window. Here, see, if I draw a fistula here in front of the oval window, so this fistula is the fistula antefenestrum, very small fistula. But why is this fistula important? Do you know why is this fistula important? This fistula is important because it's the most common site of a very popular disease called autosclerosis. Autosclerosis is another very important disease of the middle ear. We shall discuss this disease in details tomorrow morning. And one thing you know about this disease already is the most common site, fistula antefenestrum. This question is especially important because a lot of people think that autosclerosis starts in the foot plate or the oval window or the stapes or the ossicles. All these are wrong answer. If I ask you where does autosclerosis most commonly start, if you say oval window or foot plate or stapes, they're all wrong answers. The correct answer is it starts at the fistula antefenestrum. So this much about the medial wall. And now we come to the last boundary, the posterior wall of the middle ear. Posterior boundary. In the posterior wall, you know one thing already. You know the vertical part of the facial nerve, isn't it? You know that there is already. Now let me use another diagram because there is no space to write. So I've already drawn a diagram for you. Posterior wall. You can use the same diagram if you are making notes, which I hope that you are doing, or you can draw a different diagram. So you can already see facial nerve there, and it is coming out of the foramen here. So there is to be a foramen, obviously, otherwise how will the nerve come out? And this foramen is called stylomastoid foramen. So one of the things on the posterior wall is facial nerve, vertical part through stylomastoid foramen. This is in MCQ sometimes, not a very popular question, but they can ask you facial nerve comes out of the middle ear through which foramen? Stylomastoid foramen. So lower part of the posterior wall has a foramen, isn't it? And the upper part has a door. There is a door here. Door. And this door has a name. It's called adytus. Okay, adytus is a door. Upper part is a door. Lower part is a foramen. If you remember, when I was talking about incus ossicle, I told you then that incus has a short process. Remember, and the short process fits on the posterior wall. I told you when I talk about posterior wall, I will mention about incus also. So for the short process of the incus, there is a fossa somewhere here, just outside the facial nerve. There is a fossa called fossa incudis. Look at the name. From the name you can understand this fossa has something to do with incus, so fossa incudis. And now comes the three most important names from the posterior wall. Which are these most important name? Is a facial recess. I call it FR in short. There is sinus tympani. I call it ST, and the most important lot, pyramid. Pyramid is a bone which gives origin to a muscle called stapedius muscle. So these last three names are the most important names from the posterior wall. Facial recess, sinus tympani, pyramid with the stapedius muscle, and you have to know about all these three names some few points which we are going to do next. Now before we start talking about these three things, let me tell you the location of the three things. When I use this diagram, facial recess and sinus tympani, they are located on either side of the facial nerve. So facial nerve, this side is facial recess FR, the other side is ST, sinus tympani. Okay, we'll talk about this a little more, don't worry. And what about pyramid? Pyramid is a pyramidal shaped, like this pyramidal shaped bony projection on the posterior wall. And from this bone, a muscle originates, and this muscle is the stapedius muscle. But where is this pyramid on the posterior wall? Where it is located? It is located just below the turn of the facial nerve. I'll place it here. See, the facial nerve has turned just below the turn of the facial nerve. Can you see this? I brought it here, pyramidal shape with the stapedius muscle. And because stapedius is a muscle, it must have a nerve supply, and you don't have to even guess which nerve will supply the stapedius muscle. Obviously a branch from the facial nerve. So look at the diagram. A branch from the facial nerve comes to supply this muscle like this. And this branch of the facial nerve is called nerve to stapedius. Nerve to stapedius, the name tells you it is going to the stapedius muscle. It's a branch of the facial nerve on the posterior wall, supplies the stapedius muscle. But the more important thing is that we know that facial nerve gives a branch in the posterior wall of the middle ear, and the name of the branch is nerve to stapedius. Not only this, facial nerve on the posterior wall has one more branch, and that branch is more important than this branch. And how do I draw this branch of the facial nerve? Just before the facial nerve goes into the stylomastoid foramen, it gives a branch which I draw like this. And this branch is CT. What is CT? Chorda tympani. See, on the posterior wall you can see the vertical part of the facial nerve, and you can see two branches of the facial nerve. One going to the stapedius muscle, nerve to stapedius. One is chorda tympani. We'll discuss chorda tympani a bit later. But why this? Why have I drawn this? See, you know that this is your facial nerve, vertical part. This is a chorda tympani nerve, and there is fossa incudis here. Between the three, that space is called the facial recess area. So facial recess has these three boundaries. I'll write later on so that you remember that these are the three boundaries of the facial nerve, the facial nerve, facial recess. The three boundaries of facial recess, one is facial nerve vertical part, one is chorda tympani nerve, and at the top there is fossa incudis with short process of incus. These are the three boundaries of the facial recess. So it becomes very easy if you remember this diagram to remember the boundaries name. You don't have to mug up. But before we go into that, you have to know a little bit more about stapedius muscle. Now if I ask you, where does the stapedius muscle originate from? You know the answer. Stapedius muscle originates from the pyramid, isn't it? We know this. And where is it inserted? It is inserted into the neck of stapes. Stapes third ossicle. That's where you get the name stapedius. Why this muscle is called stapedius? It has a relation with the stapes ossicle. And what is the nerve supply? I just told you. Nerve supply is the nerve to stapedius, a branch of facial. But the most important thing about this muscle is the function. What is the function? Who knows the function of the stapedius muscle? Anybody who knows the function of stapedius? Very commonly asked in the exam. Most people would know this name. It is dampen the loud sound. This is the function of the stapedius muscle. Dampen means it decreases when the sound is very loud. If you hear a very loud sound, it needs to be decreased, the loudness. That's called dampening. It is done by the stapedius muscle. How does it do this? By producing a reflex called stapedial reflex. What is the other name for stapedial reflex? It's also called acoustic reflex. Acoustic reflex or stapedial reflex is produced by the stapedius muscle, and the function of this reflex is to decrease the loudness of the sound, because loud sound can damage your inner ear. Loud sound can damage your cochlea. So in other words, it is protecting you. It's a protective reflex, stapedial reflex. Okay. Now let me talk about this reflex a little bit, because there are few questions they ask you. Now this part is going to be very, very important. Please pay attention. Please pay special attention. Let's say this is the right side of the body and this is the left side. Now if I give a sound on the right side of the ear, the sound is carried by the eighth nerve. Eighth nerve will carry this sound, because we all know eighth nerve is the nerve for hearing, to the brain stem. Remember the first diagram. The sound from the cochlea through eighth nerve goes to the brain stem, and then it goes to the cortex. It goes to the brain stem. In the brain stem, sound goes through many stations of the brain stem, many parts of the brain stem. All this we will discuss when we discuss facial eighth nerve. We will discuss that. But one very important part of the brain stem through which the sound goes is called superior olivary nucleus. It passes through superior olivary nucleus of the brain stem. Now I told you the sound goes through many parts of the brain stem. I've only mentioned one name, superior olivary nucleus. Why? Because superior olivary nucleus has a very important function. Superior olivary nucleus of right side is connected with the SON of the left side also. They are connected with each other. Meaning that if you give sound to right ear, through superior olivary nucleus, it will go to the left side also. And from there it will go to both the side of the brain. That means if you give any sound to any one ear, you will always hear in both the side of the brain, because there is a crossover of the sound. There is connection between the two sides in the auditory pathway. And this is the question they ask you: where does the sound cross over? Where is the connection between the two sides taking place? And the answer is superior olivary nucleus, where the sound crosses over. But if this sound is loud sound, dangerous sound, this sound will also go through the superior olivary nucleus to both the side of the brain. When the brain realizes this sound is too loud, it can damage, then it sends the signal to the superior olivary nucleus, and then via the facial nerve of both the sides, the signal comes to the stapedius muscle of both the side, because now it is signal is coming both the side. And when the muscle receives this signal from the seventh nerve through the brain, the muscle contracts. When the muscle contracts, the ossicles decreases vibration. This side also, the ossicle will decrease vibrating. And if the ossicle cannot vibrate, the sound cannot travel, So this is dampening on the right side. If the sound is not going, it is decreased, dampens on this side, and it dampens on this side. So this is the arc or curve of the stapedial reflex. Okay, there are 2 or 3 takeaways from here. Number 1, even if you give loud sound to one side, the reflex will happen on both the sides always. In a normal person, it will always happen on both the sides. And what are the things that I need for a normal reflex? The structure that I require for normal reflex is the 8th nerve. I need the superior olivary nucleus. I need the 7th nerve. I need the stapedius muscle. I need ossicles. All these should be functioning normally for a normal reflex. If any of the 5 is damaged, then there is absent reflex. And if the reflex is absent, that condition is called hyperacusis. So you have to know the meaning of this word called hyperacusis. Hyperacusis is the term that is used where the stapedial reflex is absent. And how many nerves are needed for this reflex? 2 nerves. 7th nerve, 8th nerve. 8th nerve is the afferent nerve and 7th nerve is the efferent nerve in the reflex. Remember, afferent nerve is 8th nerve, 7th nerve is efferent nerve. Now tell me, what will happen if I give the loud sound to the left side? If I give loud sound to the left side, the same thing will happen but from the other side. This time the left side 8th nerve will carry the signal to the left side superior olivary nucleus. I am drawing with left side with blue color, and this will go to the left superior olivary nucleus to the right side. Then both the 7th nerve will bring the signal to both the muscles, and the more the muscle will decrease digression and both sides will have a reflex, which is very obvious. So whether you give loud sound to the right side or loud sound to the left side, the reflex will happen to both the sides in a normal person all the time. Okay, now tell me, suppose I tell you the 7th nerve of the right side is damaged. Okay, now there is a question coming up for you, MCQ. 7th nerve on the right side is damaged. If I give loud sound to the left ear, which of the following will happen in this patient? The 7th nerve on the right side is damaged. You are giving very loud sound to the left ear. Which of the following may be seen in this patient? A, absent reflex in the ipsilateral side. Please write the answer in the comment box. Okay. A, you have to write A, B, C, D. A choice is absent reflex on the ipsilateral side. Choice B is absent reflex on the contralateral side. So choice C is absent reflex on both the sides, and choice D is normal reflex on both the sides. So what is your answer? Let's see. What do you have to say? Okay. Please write in the comment box. I'm waiting for your answers. So the question says the 7th nerve on the right side is damaged, and if you give loud sound to the left ear, will it cause absent reflex on the ipsilateral side? A. Will it cause absent reflex on the contralateral side? B. Will it cause absent reflex on both the sides? C. Or will there be normal reflex on both the side? D. I've got 6 answers, 6 people answering, and all are correct. They all said B. Sanjana, Malini, Ridhi, Garg, Rak AC, Saifa Saji, Meera, and Adnan. So they have all said Alain, Safna again, absent reflex on the contralateral side is a correct answer. That's the correct answer. So like this, they can prepare so many questions from this particular, graph, and that's why I've drawn this graph so that you remember. Suppose they say in the same patient, if I give the sound to the right ear, what will happen? If the 8th nerve is damaged, what will happen? So like this, they can prepare so many questions. So please remember this so that you can answer such questions. Very easy. So good. So everybody, Meera, Adnan, Alain, Safna, made life 1797. What is that? What number is this 1797? इसे किसकी याद आती है? बर्थडे है तुम्हारा? एलेक्स, लोन वुल्फ, अक्षय, अस्मिला, amethyst. So everybody got it right. That means you know the concept, you understand the concept. Okay, and then we are left with facial recess and sinus tympani. These two names. Facial recess, I've already told you the three boundaries. One boundary is facial nerve, second boundary is chorda tympani, and third boundary is fossa inquiris. Is it buffering? Okay, so sinus tympani is important because it is surgery is difficult here. In sinus tympani, the surgery is difficult, and that's why this area is important. Which means, even if there is a disease in the sinus tympani, and you do surgery, after surgery also you cannot remove the entire disease. So it's a very difficult area. And the disease is going to remain even after surgery. So if the disease is left over after surgery, that is called residual disease. Some books use the word recurrence of disease. And this is what they ask in the exam also. In which part of the middle ear residual disease or recurrence of disease is most commonly seen? The answer is sinus tympani is the area where residual or recurrence of disease can be seen most commonly. Okay, simple. So this will complete the posterior wall. In fact, it completes all the walls of the middle ear, including the ossicles and the compartments. Basically, we have completed the middle ear anatomy. There are some images that I have to show you, but I think because it is buffering in some centers, we have to wait for those guys. So what we'll do is we'll take a break here. We'll take a break for about 30 minutes. In the meanwhile, I think the problem will get fixed, and you also have a cup of coffee, tea, go to the washroom, freshen up, because I will talk about these images, and then we'll talk about these images, and then we'll talk about inner ear anatomy. All this is to be done. Anatomy of ear is very important because we have to spend a lot of time. So I think we'll take a break here.